Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Hello, I'm Dr. Adam Stryker, editor and host of Central Line. Today we're going to discuss the use of opioids in patients with liver disease, a topic from the 23A issue of ACE, or, as many of you may know it, Anesthesiology Continuing Education. We're going to talk about it with one of the ACE editors, Dr. Shamsuddin Akhtar. Welcome to the show, Dr. Akhtar.
Thank you for having me, Dr. Stryker.
First, let's start with a little bit of an introduction. Typically on the show, we have our guests tell a little bit about themselves to our listeners and how you ended up in the role you're currently in regarding the society. So specifically ACE, if you don't mind talking a little bit about yourself and how you got there.
Thank you so much. Adam, as I tell people, I'm PGY 35. So I've been in this business for a bit. Initial part of my career was vested in perioperative medicine, which I still am, concentrating more so on cardiopulmonary issues, specifically preoperative cardiac testing. And it just so happened that I always had a strong interest in these areas. I was boarded in critical care, and it kind of evolved into specialty related to anesthesia for geriatric patients. My interest in these areas obviously continues to evolve and is determined by and directed by what I see clinically. And since I spend more and more time in the surgical ICU, I tend to see a lot of patients with liver diseases, either coming with liver diseases, coming after liver transplants, or suffering from liver diseases while they are in the ICU. And obviously, we all experience these patients when we are taking care of them in the operating rooms. So this is how I got involved in this. My involvement with ACE stems from my interest in education and academia. And a few years ago, when the opportunity arose, I thought I could contribute in that fashion. And now I am very fortunate to be involved with ACE as one of the editorial board members. Learned quite a bit from my colleagues, and it is a fun and very gratifying experience.
Excellent. Well, let's delve right in and talk about the topic of interest. Now, if you don't mind, maybe just review a little bit for our listeners how the liver metabolizes opioids and how that might differ in patients with cirrhosis.
Yes. So as we all understand, that liver is a big factory, and that's where most of the metabolism happens. In terms of opioids, there are two primary mechanisms and chemical reactions by which the liver metabolizes drugs, specifically opioids. There is an oxidation reaction, which involves the P450 enzyme systems, and that's the system which metabolizes the opioids the most. And then there is a second group of chemical reactions, which consists of conjugation and glucuronidation in the liver. So these are the two basic mechanisms by which the liver metabolizes a whole host of opioids and many other drugs. Now, in patients with cirrhosis, or as we would call severe liver disease, it changes because cirrhosis by itself causes different issues. Not only does it affect the metabolism, but it also affects the protein content, because liver is involved in protein synthesis, the albumin, the alpha glycoproteins. It also affects the total body water that the patients have. It affects how the blood flow is going through the liver. And then we have conditions that are related to the kidney and the liver, which we tend to call hepatorenal syndromes. So all these factors at various permutations and combinations affect the metabolism of the liver in patients with liver disease. Having said that, it is also important to note that liver has a lot of reserve. And hence, the most impactful issues happen when the liver disease is quite severe. And that typically means that people have either high MELD scores or, as in the past, when people had Child's class C liver disease, which involved effect on synthesis as well as ascites, as well as hepatic encephalopathy. So patients with Child's class C are the most affected in terms of opioid metabolism.
Okay, well, we're going to talk about several narcotics specifically and the pharmacokinetics in this particular population. Let's start out with morphine first. Talk a little bit about how morphine is affected in this particular patient population.
So 90% of the morphine is metabolized in the liver, and then the metabolites are excreted in the kidneys. Morphine is metabolized into two main metabolites by a glucuronidation pathway, which is the morphine 3 glucuronide, also called M3G, and the morphine 6 glucuronide, which is M6G. The M6G is the one that is considered an active metabolite, but the percentage of these are not the same. There is more of M3 metabolite rather than the M6G metabolite. However, since the M6G metabolite is the active one, in patients especially who develop liver or kidney dysfunction, it tends to accumulate pretty significantly. So what happens is that not only are the metabolites increased, but the concentration or the amount of morphine can also be increased in these patients with severe cirrhosis or severe liver disease. And hence, the free morphine may be available. One of the big reasons for that is that morphine has a very high extraction ratio, which essentially means that the liver gets its blood flow and the drug is extracted by the liver. If the liver is not functioning as well, which is possible and which is seen in patients with severe liver disease, then a lot of blood may bypass, and hence you may end up with higher concentrations of the parent drug. In case of morphine, that means the morphine amount is increased, and hence it can have increased effects. The half-life is thought to be increased in multiple studies, but there are some studies to suggest that the half-life is not significantly increased. So that is what we see with morphine in patients with liver disease. Interestingly, it is also dependent on what kind of conditions the patient is suffering. So alcohol liver disease in some ways can have different effects versus infectious liver disease, and hence that makes it complicated. But the general consensus is that morphine's pharmacokinetics is altered, that its drug dosing needs to be modified in patients with severe liver disease and ideally should not be used in patients with liver disease.
Well, now let's compare that to fentanyl. How is that different in this particular scenario?
So fentanyl is a synthetic opioid. Fentanyl, sufentanil, hydromorphone, they tend to be impacted less with liver condition. So they are considered safe. Having said that, we also understand that the context sensitive half time for these drugs is different. So it also depends on how long these medications are used. Compared to morphine, it is suggested that fentanyl and sufentanil are not affected as much or at all by liver dysfunction in severe category.
Okay, and then what about hydromorphone?
Hydromorphone. So hydromorphone is also falls in the similar category. There are a little bit of discrepancy in terms of the data. There are some studies which suggest that hydromorphone is affected, but the consensus again tends to be that hydromorphone is safe in patients with severe liver disease and can be used. It is advised that patients who are getting either infusions of hydromorphone, which we don't tend to use, or in patients with concomitant renal disease, the dose should be adjusted.
Okay, well, just to back up for a second, when we're talking about adjusting dosages and being cautious or even restrictive on the usage of these medications in patients with liver disease, are we talking about the beta elimination half-life being prolonged? Are we talking about the clinical efficacy being shortened or prolonged? If you don't mind, touch a little bit upon the specific pharmacokinetic variable that
Yeah,
we're really examining.
you're right. So for morphine, for which we have the most data, the half-life tends to be prolonged. The amount of free drug tends to be more. So those two factors tend to contribute to adjustment in the drug dosing. And hence, it is recommended that the drug be dosed 50% less of the standard and be dosed less frequently. So, for example, if you were going to give a medication, if you're going to give morphine for a clinical scenario and you were going to administer 2 milligrams every 2 hours, it is recommended that you give and administer that at half the dose and probably twice the duration. So 1 milligram every 4 hours to begin. In terms of hydromorphone, the half-life doesn't seem to be as prolonged, but the recommendation still is that it should be given at a lower dose and a lesser frequency to begin with. It is quite possible that the patient may still need the medication at a regular frequency, but it is less so of an issue than morphine.
And then fentanyl's a little different.
Yes. And fentanyl half-life is not affected by severe liver dysfunction, and hence it can be administered at a regular dose and interval.
But bolus dose as opposed to infusion,
Yes,
that might affect fentanyl then.
absolutely.
Talk a little bit about methadone.
So methadone is an interesting situation. As many of our listeners are aware, methadone is an old drug which is now again coming back into practice as a drug which is used for the management of acute pain. And we are seeing a lot of methadone being used, especially in ambulatory practices as a single dose. Now, what happens in liver disease is that the T half beta, which is the elimination half life, is increased, and the volume of distribution in these patients with severe hepatic function also is prolonged. So that happens. Now, interestingly, if patients have developed liver disease because of chronic alcohol abuse, what may happen is that the metabolism of methadone may be actually increased. However, if somebody has developed acute or in acute state, the metabolism may be depressed. So it kind of fills up the picture, but definitely the T half beta, the elimination half life is increased for methadone. Since it is unpredictable in that regard and it is a long acting drug, the effects can last anything from 8 hours to more than 50 hours with significant variability. It is not recommended to be used in patients with severe liver disease. So, in acute situations, just like we would use for acute postoperative management, it should be avoided generally in patients with severe liver disease.
All right. Now talk a little bit, if you don't mind, about using these medications or taking into consideration these variables when working with elderly and or frail patients.
Yeah, so this is very important. As we understand, more than 50% of our patients go through procedures are older than 65. Okay. Now, the definition of geriatrics is variable, but generally speaking, we say somebody older than 65. Irrespective, we know that there are changes in body fluids, in proteins, in lipids, in fat content, blood volume as we age, and those are part of physiological processes. Furthermore, our elderly patients also are likely to develop frailty and suffer from frailty. And again, the definition of frailty is very variable. There are multiple indices uh, that have been suggested, have been used. By some account, there are more than 20 different indices in that regards. Irrespective, if you look at frailty, the commonly used clinical frailty score or the Freed score, all these patients, because of their frailty, aging, and they're all kind of like, it's sometimes difficult to differentiate one versus the other, are at an increased risk of complications with medications. What we know is that they are at an increased risk of developing respiratory depression. They have low muscle mass, so the water content is changed. They have increased lipids, so if you give the medication, they can work as a storehouse. And then there are issues related to their renal dysfunction as well as their liver dysfunction. So when you combine all the factors that change the pharmacokinetics and potentially the pharmacodynamics of these patients, it is generally recommended that all anesthetics should be dosed less. And we have strong data to support that the requirement of opioids also should be decreased in this population. So that is an important thing to keep in mind when we are dealing with old and frail individuals. One other factor that also complicates these issues is that many of these elderly patients are taking medications for the diseases that they are suffering. So when in an acute situation of postoperative pain, you add a bunch of medication to the polypharmacy that these patients are already being exposed to, you can end up with significant frequency of untoward effects. And that could translate into significant cardiopulmonary complications. So, specifically in the elderly, one should assume that the renal function, the body composition, the polypharmacy, and the CNS changes, which have an effect pharmacodynamically of these drugs, one should be decreasing the dose of these medications, and one should be very careful.
Finally, is there anything new here? Are there any new studies or any new information that practitioners probably didn't know about that should know now?
So I think a couple of things. When we say new, it is very interesting. It is typically noted that it takes about 15 to 18 years for practice to change. When there is data that is established, and then it takes another 15 years before it is adopted or adopted by majority of the practitioners. So when we say, is there anything new that is here, is difficult to say, but I can say that most of the studies that have quoted and have been established, this data has been established probably for more than 15 to 20 years, if not more, in some scenarios. What is new is that we are seeing more and more of our elderly patients going through procedures that potentially they would not be going through 20 years ago. Number two, we are also seeing that some drugs like methadone are now being used for acute postoperative pain management. We are also seeing that many of our patients are using a host of different medications, like they could either be suffering from opioid use disorders, they could be suffering from alcohol use disorder, they could be suffering from other substance use disorders, and then polypharmacy. So I think what is more new and what is important to keep in mind is that we are now dealing with a population that is more likely to suffer from ill effects of dosing of these medications, which I also mean is that they are at risk of suffering from cardiopulmonary complications with these medications, especially in conjunction with medications that they may be taking. And that kind of makes us that, hey, we have to be more cautious and recognize that we are taking out these care of these patients who have many comorbidities, and we should be dosing them appropriately with appropriate medications. And what may be new, like for example, methadone, it may be a new application of an old drug,
Yeah.
but at the same time, it may not be the right drug for a patient with liver disease, or it may not be the right drug for a patient with liver disease and elderly, or a patient who has frailty and elderly and liver disease and kidney disease. So the drug is old, the pharmacokinetics is known, the pharmacodynamics is known, but the use of these medications in these patients is new. And that is something that we have to keep in mind when we are applying, even if they are applying older drugs to new clinical scenarios.
Certainly. Well, before I let you go, I do want to have you talk a little bit about your role with the ACE program. And if there's anything you would like our listeners to know about the ACE program, what would that be?
I've been involved with ACE now for a number of years. And as a editor, as a co-editor, it has been a great educational experience for me. People who do ACE really do it because they love doing that. They love serving. They are really invested in education of our community, and they want to present the most practical, the most up-to-date, and clinically relevant information to our audience. It has been an honor to work in conjunction with the colleagues, and the amount of work, the amount of dedication that I have seen while working with my ACE colleagues is really commendable. And I think that's the reason that ACE as a product is so good. And it is well received not only by our practitioners, but by the residents and fellows and anybody who is involved in the business of anesthesia and critical care.
Well, Dr. Akhtar, thank you so much for joining us. It truly is a great program, and I encourage anyone who has not checked out the ACE program to do so.
Thank you so much, Dr. Stryker, for having me and discussing about this important issue, which is clinical pharmacology in our various populations that we take care of day to day.
Excellent. And thank you again. And for the listeners who are interested in checking out the ACE program, please visit the website. That's asahq.org/ACE or ACE. So thanks for joining us on this episode, and please tune in again next time. Take care.
Hello, ASA. I'm Dr. Patrick Gia, your ASA president, and this is the Monday Morning Minute. First, I joined Dr. Adam Stryker to discuss the specialty, the society, and the future during the president's episode of ASA's Central Line podcast. Next, resident component president Dr. Natalie Coombs took over the March 23rd Monday morning outreach. She shared her experience as an ASA member and resident component president, the valuable resources developed for residents, and why residents should get involved in the society. Last, in late March, I was joined by fellow executive committee members in D.C. for meetings with federal lawmakers. We addressed low Medicare payments, reining in the abusive behaviors of big insurance, and improving the No Surprises Act to ensure that anesthesiologists receive fair payments. Well, that's it for now, and I hope you'll follow us on your favorite social media channels and check out my weekly Monday morning outreach.
For more detailed and timely information, don't miss Dr. Guillaume's Monday morning outreach email delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. ACE keeps you on solid ground with anesthesia fundamentals and evolving best practices. Review and renew your knowledge with 200 multiple-choice questions and insightful discussions that you can complete at your own pace. Try a sample question at asahq.org/ACE. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.